Welcome to StudyNeuro, where we bring you high-yield neuroscience education and practical clinical pearls. In this presentation, we will explore the major causes of low back pain and how they can be grouped into different clinical categories. The goal is to understand how common mechanical pain differs from specific spinal disease and how the clinical pattern can guide further evaluation. Low back pain has many possible causes. Some begin in the muscles, joints, discs, or bones of the spine, while others result from inflammation, infection, trauma, or tumors. We will also consider pain that comes from outside the spine, such as disease affecting nearby organs. The cause matters. It determines the next step. We will examine disc-related and degenerative conditions, as well as neurological and structural problems that can produce back pain. We will also discuss features that may point towards inflammatory disease, infection, or cancer, particularly when symptoms do not follow the usual pattern of mechanical pain. Some patients have pain referred from another part of the body. This is important when symptoms do not fit a typical spinal pattern, because the true source may be vascular, abdominal, or related to another organ. Finally, we will focus on red flags. These are clinical features that raise concern for serious underlying disease and may require urgent investigation. By using a structured clinical approach, we can identify patients who are likely to have uncomplicated low back pain and recognize those who need targeted assessment and treatment. For more high-yield neuroscience education and clinical pearls, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X. Low back pain is a symptom, not a single disease. It can result from common musculoskeletal problems, but in some patients, it may signal a serious or even life-threatening condition. Clinically, the causes can be grouped into broad categories based on where the pain comes from and how it presents. Most patients have nonspecific mechanical pain, which usually does not have an identifiable serious underlying cause. Others may have nerve-related pain or a specific spinal disorder. The priority is simple: find the serious cases early. A careful history and examination help identify the small proportion of patients who need targeted investigation and treatment, while allowing most others to receive appropriate conservative care. Nonspecific low back pain refers to pain where no single underlying disease or structural problem can be clearly identified. It accounts for most presentations of low back pain. That is the common pattern. The pain may come from several structures around the spine, such as the discs or facet joints, while muscles and ligaments may also contribute. Because these tissues can interact, it is often impossible to identify one exact pain generator with certainty. Several factors may influence symptoms, including biological susceptibility, physical activity, body weight, and psychosocial factors. These factors can act together and may affect how pain develops and persists. Imaging can be misleading. Degenerative changes are common, even in people without pain, so an abnormal scan does not necessarily explain the patient's symptoms. The intervertebral disc is one possible source of low back pain. As the disc degenerates, it can lose hydration and height, while small tears may develop in the outer annulus. These changes can expose pain-sensitive nerve endings to inflammatory substances, contributing to what is called discogenic pain. It can also lead to disc herniation, where disc material protrudes or escapes beyond its normal boundaries, and may cause back pain or compress a nearby nerve root. Inflammation matters here. However, disc abnormalities are also common in people without symptoms, so imaging findings must always be interpreted alongside the patient's history and clinical examination. The facet joints are small synovial joints at the back of the spine that help provide stability and guide spinal movement. They can become a source of pain when degenerative changes affect the joint or when inflammation and irritation develop. Facet-related pain is usually felt in the lower back, often beside the spine, and it may spread into the buttock or upper thigh. It is typically axial, rather than following a clear nerve root pattern. That distinction can help. Other structures at the back of the spine can also cause pain. Stress-related injuries involving the pars interarticularis may lead to spondylolysis, particularly in patients exposed to repeated spinal loading. Diagnosing facet-mediated pain remains difficult. Imaging may show degenerative changes, but these findings alone cannot reliably prove that the facet joint is the actual source of pain. The muscles and ligaments around the lumbar spine can also contribute to low back pain. A strain may develop when these soft tissues are overloaded, fatigued, or exposed to repeated physical stress. Pain may appear after an activity that is more demanding than usual, especially following unfamiliar exercise or repetitive movement. It can also develop after prolonged physical effort. The symptoms are often localized and may worsen with movement. But there is often no clear injury. Many episodes of acute low back pain occur without an identifiable event, which is why the exact cause can sometimes remain uncertain. As we age, normal wear and structural changes can affect different parts of the lumbar spine. These changes may involve the discs, facet joints, or the alignment of the vertebrae. Several degenerative conditions can develop, including lumbar spondylosis and narrowing of the spinal canal. Some patients experience mainly axial low back pain, while others develop nerve root pain or neurogenic claudication, with symptoms that worsen during walking or standing. The clinical picture can vary. Progressive nerve compression may eventually cause weakness, sensory changes, or other neurological symptoms. But imaging must be interpreted carefully. Degenerative changes are very common with aging and do not always explain the patient's pain or functional limitations. Spondylolisthesis describes the displacement of one vertebrae in relation to another. It can develop for different reasons, including a defect in the pars interarticularis or degeneration of the discs and facet joints. The symptoms depend on the degree of displacement and whether the nerves are compressed. Patients may experience axial low back pain, while some develop radiating leg symptoms or neurogenic claudication. Hamstring tightness can also occur, particularly in certain forms of spondylolisthesis. The underlying cause matters. Understanding the type of spondylolisthesis helps guide further assessment and treatment. Lumbar spinal stenosis occurs when the spinal canal or the openings for the nerves become narrowed. This can develop as degenerative changes affect the discs, facet joints, or supporting ligaments, and it may also be associated with vertebral displacement. Patients may develop leg pain, numbness, or weakness, particularly during standing or walking. Neurogenic claudication is a classic feature, with symptoms often improving when the patient sits or bends forward. Lumbar radiculopathy is different. It occurs when a spinal nerve root becomes irritated or compressed, commonly by a herniated disc or narrowing around the nerve. The symptoms often follow the distribution of the affected nerve root. That pattern can provide an important clinical clue. Low back pain can follow injury to the vertebrae or other spinal structures. Compression fractures are common in vulnerable patients, while more severe trauma can produce burst fractures or injuries involving the posterior elements of the spine. The risk is higher when bone strength is reduced, particularly with osteoporosis, advanced age, or prolonged corticosteroid use. Even minor trauma can cause a fracture in these patients, while high-energy collisions and sports injuries may produce significant spinal damage in otherwise healthy individuals. New severe back pain after trauma is a red flag. Fracture must be considered, especially when important risk factors are present, and prompt assessment is needed to identify possible instability or neurological compromise. Inflammatory spinal disorders are conditions in which immune-mediated inflammation affects the spine and related structures, causing persistent low back pain and stiffness. Examples include axial spondyloarthritis, ankylosing spondylitis, and arthritis associated with other inflammatory diseases. The pain often begins at a younger age and develops gradually, with morning stiffness that improves with movement rather than rest. Night pain and alternating buttock pain may also occur. This pattern is important. Other body systems may provide useful clues. Patients can have inflammation affecting the eyes, skin, or bowel, while enthesitis, which is inflammation where tendons or ligaments attach to bone, may also be present. Recognizing these features helps distinguish inflammatory back pain from common mechanical causes and guides appropriate referral and further evaluation. Spinal infection is an uncommon cause of low back pain, but it can become life-threatening if diagnosis and treatment are delayed. It may involve the vertebral bone, the intervertebral disc, or the epidural space around the spinal cord and nerve roots. The risk is higher in patients with reduced immunity, diabetes, recent bloodstream infection, or a history of intravenous drug use. Recent spinal surgery or other procedures also increase concern, particularly when persistent pain develops without a clear mechanical explanation. The pain is often persistent or progressively worsening and may be accompanied by fever, general weakness, or raised inflammatory markers. Neurological deficits can appear as the infection advances. This is serious. A spinal epidural abscess with worsening neurological function is a medical emergency. Rapid recognition and urgent treatment are essential to prevent permanent neurological damage. Congenital and structural disorders can also contribute to low back pain. Some are present from birth, while others develop as the spine grows or ages, affecting its shape, alignment, or mechanical function. Conditions such as scoliosis, kyphosis, spondylolisthesis, or Schwerman's disease may cause pain directly, while abnormalities such as transitional vertebrae can change spinal mechanics and increase stress on nearby structures. Bone disorders, including osteoporosis and Paget disease, may also contribute to pain or structural weakness. Not every abnormality causes symptoms. The clinical significance of an anatomical finding must always be judged alongside the patient's history, symptoms, and physical examination. Imaging alone does not establish the cause of pain. Low back pain does not always come from the spine. Referred pain occurs when a problem in another part of the body is felt in the lower back, even though the spinal structures themselves are not the source. The cause may be visceral, involving organs such as the kidneys or gastrointestinal tract, while pelvic conditions can also produce similar symptoms. Vascular disease, including an aortic aneurysm, is particularly important because delayed diagnosis can be life-threatening. Other sources include hip disorders, sacroiliac joint problems, and herpes zoster. The pattern matters greatly. Pain that does not behave like typical mechanical back pain should prompt consideration of a referred or non-spinal cause and guide further evaluation. Low back pain has many possible causes, and a structured classification helps clinicians organize the differential diagnosis. The categories range from common mechanical pain to conditions affecting the nerves, spine, or organs outside the spine. Nonspecific and mechanical pain are the most common, while degenerative and disc-related disorders involve changes in the spinal discs and joints. Neurological causes include nerve root compression and narrowing of the spinal canal, whereas structural problems involve abnormalities in spinal alignment or stability. Trauma can produce fractures or other spinal injuries. Inflammatory disorders, such as axial spondyloarthritis, cause persistent inflammation, while infections may affect the discs, vertebrae, or epidural space. Neoplastic causes include metastatic disease and spinal tumors. Referred pain can also arise from organs outside the spine, including the kidneys, blood vessels, gastrointestinal tract, or pelvis. The clinical pattern matters most. Correctly identifying the likely category helps guide further examination, investigation, and treatment. To conclude, low back pain can arise from many different conditions, ranging from common mechanical problems to serious spinal or systemic disease. Most cases are nonspecific and improve with appropriate conservative care. However, clinicians must recognize red flags that may indicate fracture, infection, cancer, or significant neurological compromise. These cases require prompt attention. A careful history and physical examination guide the initial assessment, while imaging is used when clinically indicated. Imaging findings should always be interpreted alongside the patient's symptoms and examination. The clinical picture matters most. Early recognition of serious disease allows timely treatment and can help prevent permanent complications. Thank you for watching. For more high-yield neuroscience education and clinical pearls, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X. If you found this video helpful, please like, comment, share, and subscribe. Thanks for watching, and stay tuned for more from StudyNeuro.